So, good morning, everyone. Maybe what I'll do is I'll just give a brief description of Dr. David Boyd, after which this lectureship was named after, and then we'll ask our guest to take it away. So this is the first grand rounds of the year. So thank you everyone for joining us. Um, this lectureship is named after Dr. David Boyd. David Boyd was a surgeon from Seattle who actually graduated from McGill in 1963. He then went off to Cook County to do his surgical training and became the first fellow at Shock Trauma. He is a world-renowned surgeon, trauma surgeon, who actually made a major impact on emergency medical services and pre-hospital. So this lectureship, this first Grand Rounds lectureship was named after Dr. David Boyd. And today we have the pleasure of having Dr. Andrew Beckett join us for these rounds. Um, I'm sure all of you remember Dr. Beckett. He was with us from 2014 to 2020. He was one of our trauma surgeons, a leader here at the MGH. Um, Andrew has had an amazing career. He is the Chief General Surgeon for the Canadian Armed Forces. And he has a great research profile looking at whole blood, looking at transfusion practices. And he's been actually a world leader in transfusion medicine and surgical and trauma care. He is currently the chief of trauma at St. Mike's Hospital. So he left us in 2020 to take that role on. We are super happy for him. He's been doing an amazing job there. So it's an honor and privilege to introduce Dr. Andrew Beckett, not only as a world-renowned trauma surgeon and military surgeon, but as a friend to all of us. So Andrew today is going to talk a little bit about their process, their journey to the American College verification and certification as a trauma center, and that is a goal and mission of ours. We've recently embarked on that journey. It's going to be a sort of a 2 to 3 year project for us to become verified as a level 1 trauma center. And I'd like to welcome Dr. Beckett to share his insight uh, on his journey.
Thanks so much, Kosar. It's really a great pleasure to be back at McGill, albeit virtual. Lots of familiar names and faces popping up on the screen, and yeah. So it's and one thing I've learned about this whole process is having going through ACS verification for your trauma center. It's really important to have friends around. Around North America to help you get through this process because it is a big change. And I think this lecture is really, it's the value of the ACS COT verification process. And it's about, having time for a change in Canada about trauma standards and trauma verification. And so I hope to give you some moral support and also some helpful ideas to push your trauma program forward, and for the general folks in the division and as well as the department to understand why it's so important to have verification. No relevant disclosures. So we're going to talk a little bit about a little bit of history of trauma center accreditation and verification at that was through Trauma Association of Canada and Accreditation Canada. And why do we, decide to undertake the VRC process, is the verification process, and how we did it, and why it should be the way forward for all centers within Canada. And then we'll just have a bit of a summary there. You know, Canada is, we've always had a sense that we want something of our own, but we weren't quite sure how to do it. And there's been numerous valiant attempts to get some kind of trauma verification system up and running across the country. And a lot of the efforts have been successful for temporary periods, but they were never sustainable, mostly due to funding and lack of resources to get it going. And the first one that a lot of folks from McGill were, including Tarek Razik, is the TAC trauma system accreditation guidelines, and what they were really focusing on is accrediting trauma systems across Canada. And a lot of the standards were based on the American College of Surgeons Orange Book, or whatever version of the book of the American College of Surgeons standards. And so they were taking a lot of what was required by the American College and sort of applying it to the Canadian setting. And then that morphed into the Trauma Distinction Program under Accreditation Canada, and which there was a lot of hope at the time that it was going to be robust and have more resources to do, but it wasn't really well funded and it wasn't well resourced to do the job. And so it was becoming increasingly clear that it wasn't offering much value to trauma centers. And really the process, really, the MOU had actually ended in 2018, in 2015, 2018. And and I had some conversations with them, but they finally wrapped up their process in 2023, and because just there was a sense that it wasn't delivering what it was supposed to deliver. And of course, there's INES within Quebec, which you all know about, for accrediting trauma centers. And so the current state is right now is so in Quebec. The INES is similar to a U.S. state level verification, so something like you might see in Illinois or New York. And now the TAC accreditation process is defunct, and the AC trauma programs of distinction that was truncated in 2023. So where we are right now. So right now there was nothing really in terms of any kind of verification system or any kind of thing happening. And so there were some number of reasons why we decided to move ahead with a full verification, strategic and for local reasons as well as national reasons. And so why trauma was designated as a priority in the hospital strategic plan. So we needed to show that we were world class. And how do you show that? We had to prove it. And I think there's a lot of talk about world class, but what does it really mean? And I think we realized that we wanted to be considered world class, we had to have some kind of verification system. And Sunnybrook under Avery Nathans had already started the process. And so we knew strategically within the U of T milieu in the Toronto region that we would have put us at a disadvantage in terms of other negotiations going on for resources and things like this. And also the thing we realized importantly was the VRC process was to offer a way for us to leverage resources from our executive, because trauma, going to the executive and say, well, we need things for trauma, like, well, why? You guys just need some stitches and a bit of OR time, and why do you guys need this stuff? And it seemed a bit of annoyance. And so we're offering something to them, is like, look, we can have this verification, can be a world leader, and this gives them something to do. And it also gives a list of things that your trauma center is deficient in. And we had a few deficiencies that we knew about going ahead of time. And so we had to, get in line with all the neurosurgeons and the heart surgeons and everybody and say, like, okay, these are the things we need to, because we have an international, North American body saying that we're deficient in these areas. And there was other processes starting in the Ontario region about having level 3 trauma centers within Ontario. And we were helping them out, and they were, we were reviewing them, and they were starting to ask, well, who's reviewing you guys? Who's saying that you guys are a good trauma center or not? And our last external review was done in 2014. So, it was like over a decade ago now, and really nothing had been done since then. So in the end, the other thing we realized that it was the right thing to do for our patients, to get them the resources that the patients needed. So, the American College of Surgeons, it's been around for a long time, and this is the verification, review, and consultation process, which you're all familiar with. So, it's dedicated to improving the care of the surgical patient and safeguarding standards of care. It's developed programs in injury prevention, ensure optimal patient outcomes across the continuum of care. And the quality programs include the TQIP, which you'll have to do if you become, you probably will have to do if you become part of the ACS VRC. I understand there's some negotiations going on right now that in Quebec, and you have the best practice guidelines. You have the VRC program. And so there's a lot of things that it offers. And, this is a long-standing program, probably one of the longest ones. And, over 100 years ago, this group of surgeons from the ACS, they started up the program, and it really started with the journal. And also they had an annual clinical congress. And this was under the auspices of Frank Martin, who is really a legend in surgical education. Right. And there's people that have there's a lot of folks that they do have some American antibodies, particularly right now, because of the ongoing geopolitical issues in the world. But the ACS was set up as a North American Society of Surgeons, not just an US-based one. So this is really the Pan North American Society of Surgeons, the premier body. So, and there's been many surgeons that have been presidents of the ACS, and many from Montreal. And I can look at the names on the table on the left, and there's many names I recognize from walking down the halls of the Livingston building or other parts of the hospital, in the general, seeing their names, such as I think there's Dr. Elder and many doctors, and Archibald. And so there's many very famous Canadian surgeons, particularly from Montreal, that have been well represented at the American College. So the idea that it's strictly an American organization is false. And I've had to explain this time and time again. And say, well, that's why are we looking at American standards? This is we're Canada, and we should stick up for this. But you have to remember that the founding organization, it's a North American college. And so, in terms of like Canadian trauma systems, McGill has always been very lucky, and Montreal General in particular has been always very lucky to have Dr. David Mulder as a big supporter of the trauma programs at Montreal and within Canada. In fact, Dr. Mulder has been still very active with the Committee on Trauma, and looking at how things can be improved in Canada for trauma systems. So Dr. Mulder has made tremendous contributions to advancement of trauma care, not just within the Montreal area, but nationally, and also within North America and globally. So, what are the standards? So this is the current gray book. This is available online for downloading, and you go through this thing and it makes a lot of sense. And I hear from a lot of people, well, these are American standards, and why do they apply to us? And but when you read through it, it just makes sense. There's nothing that's American about it. It's what's best for the trauma patient. And I think most of folks would agree, downloading it and reviewing it. You can download it on your phone and read it. And it's a lot of the stuff makes sense for the trauma patient. It's really securing the right resources for the optimal care of the trauma patients. And that's what the verification system is. Do you have the right resources in place to care for trauma patients? So, and also it tells you what kind of personnel you need. And also looks at your institution's commitment to trauma care, the readiness, the resources, what are your performance improvement processes? And this is a very big thing within the ACS VRC process is what are your performance improvement processes? So you have to be really relentless on quality improvement to be to be a validated trauma center. Like you really have to dig down and have sometimes, I have to say uncomfortable conversations with people about why things are substandard and how you can make things better in an honest and honest and collaborative way. So, to obtain that 3-year verification, you must meet all the standards. So we did ours in a few years ago, and we're starting our next verification cycle now. So we're going to have our verification visit in probably in October of 2026. So we're already starting. So it's every 3 years. So it is a big commitment. And they expect to see some, gradual improvements every time that they come and see you. So, it is a big commitment, but I can tell you it does improve patient care. So there's 3 levels of trauma center verification with different levels of resource expectations depending on the level. The level 3 centers are they're more community hospital type programs. Level 1 trauma centers would be like an academic trauma center, which Montreal General would be considered. And a level 2 center is basically a level 1 center without the research component. So, the level 1 centers, and you're also expected to provide system leadership, which I know there's many leaders under folks that have been working at Montreal General for many years, including Kosar and his predecessor, Tarek, that have led the trauma system in the region. So, and so level 2 centers, they provide the initial definitive care, but they're really not the system leaders. But so they don't have that system leadership aspect to them or the research aspect to them. So these are the selections of standards. These are the sections, they're going to go through all your equipment, your personnel, your patient care expectation and protocols, your data and surveillance and systems, your performance improvement and patient safety, or as they call it, PIPs, education, your professional and community outreach. And, one of the things with the outreach thing, you don't realize that you have to do is they kind of the ACS kind of makes you do the right thing all the time. And it's like a cookbook for doing the right thing. And one of the things that we've been having to do is work more with our EMS colleagues and both Orange and Toronto paramedics for education and QI processes. So we have to interact with them a lot more. And I think those collaborations are very meaningful. But, in the normal course of the day is, that's something when you're not being sort of have a force function to do it, it's easy to say, well, we'll get back to them next year or something, we'll do that. But this makes you do it. So a lot of things here, that, they make you do the right thing and they really hold you to it. And so we'll talk a little bit about the PIPS process here. So, one of the PIPS processes that we have is, and this is one of the main sticking points that people say, well, this is why we can't do the ACS program in Canada, the ACS VRC process in Canada, because you have to do in-house call. And that's totally false. The standard is at least 80% of the time, the trauma surgeon must be at the patient's bedside within 15 minutes at level 1 or level 2 centers, or within 30 minutes at level 3 centers of patient arrival. And people say, well, we can't do that. It's impossible. It's possible. And both Sunnybrook and us have shown that you can do it. And it's 80% of all the surgeons. And so it's a collective average. So it is doable. And well, if you look at what the standards are, at least in our city, our provincial reporting guidelines, it's 15 minutes as well. It's just prior to that, nobody was really being accountable to those standards. So they said, well, I'll send a resident to see or whatever. So this is a standard, and this is sort of one that you have to meet, or else you're not going to pass. So this is a type 1. So again, it's a type 1. If you didn't pass, this would be a critical deficiency. The applicability across the levels of trauma centers and information on how the standard will be measured and the resources that the centers can refer to for further info. So this is a typical standard that you have to go through. And so there's nuances in the Canadian system, which actually the ACS they do like, and for a lot of the reviewers and um, a lot of the reviewers, they're pretty US centric and they're very used to the US system, and so this isn't their first time coming to Canada, and so they're a little bit nervous too coming up to our system and giving advice. And one of the things they said is the single payer system, it's a strength. It's they don't have the emergency doctor TTL model. So they don't really understand that. And so you have to explain it to them, but they get on board with that. And so you're saying, oh, these are specially selected emergency doctors that have extra training to take care of trauma patients for that first 15 minutes sort of thing. And then they do start to understand it at that point. But it does, you do have to have documents explaining what the model is at your institution. And so this is something they're not quite familiar with. ICUs in Canada and here in Ontario, obviously, I know what at McGill, they're mostly led by intensivists, and this is another problem that you can kind of run into, but there is some wiggle room about how this is going to be looked at by the ACS, and there's ways around it. But you do have to have strong surgeon presence in the ICUs, and this is the ICUs within the US are, they have the SICU and the trauma ICUs and different than the medical ICUs, and ours are usually mixed. So this is it's a different ball game here, but there are ways to navigate around that. So except for Winnipeg, I think trauma surgeons do not do house call in Canada, and and some of them they have a hard time understanding like how can you run a trauma program like that. But as long as you can show that 80% attendance within 15 minutes of the trauma activation, then you're fine. And there's ways to do that. And I and I really, my thought is here at St. Mike's in Toronto, it's like we're going to have to go to an in-house trauma surgeon call model eventually. I mean, there's resistance obviously by a lot of people, but the traffic's getting worse. The activations are the ISSs are going up, and there's just more activations and sicker patients, and more penetrating trauma coming. So eventually we'll have to go there, and I'm sure with it, knowing the Montreal General catchment area and dynamics there, that probably that's going to happen eventually. I'm sure Kosar will bring that up with his next staff meeting and enjoy that conversation. But I can see where it's happening. It's just eventually you're going to have to do this, um, and so you got to explain them that, and you got to show them the data. But again, none of these are showstoppers to going for your ACS verification. So some of your surgeons and physicians may not be board certified. For example, they're internationally trained and they haven't done the Royal College exams, so it's usually okay, and there's ways around it. But sometimes you have to do some extra legwork to show that what their academic license is and their privileges, and so there's some legwork looking for that documentation, getting people to submit that. And there's some things that we just don't have here, like this OTA approved fellowship. So really, like, how are you going to do this? Now, what I recommend, and I know Kosar is doing this, is you really have to have a 3 or 4 year business plan to plan this out, because otherwise, if you say we're going to do this in 2 years, like, you're going to kill yourself. It's just a lot of things have to happen and fall into place. So the first thing you want to do is you get a program officer or program manager to take a look at this, and you do a gap analysis. All the standards are available, and you make an Excel spreadsheet, and we're happy to show ours and how we do ours. And you go into what do we have and what we don't have, and then you get an idea of what the real deltas are in capabilities that you're going to need to affect and where you're going to fail. And like, is it really possible to do this? And what is an action plan to address all these things? Once you get an idea of that, then you can book your consultative visit. So you'll book your consultative visit and they'll give you a lot of really good feedback. And even like worst case scenario, you said, well, we're just not ready to do full verification yet, but you can still get a consultative visit and like it's really excellent information of things that you could be doing better. And they'll be very honest to you. Is like we had some of our emerge docs TTL, there was a few cases that there was some craziness happening there, and non-standard practices. And they got on to me and they said, well, you know, we were talking about it and different skill set. And then actually they just told me, well, the problem is your trauma surgeons are not in the trauma bay when these things are happening. That's the problem. And I begrudgingly said, they say, okay, you're right. We have to work on getting those people in there. So that was during our consultative visit. So they'll be very frank with you. And so there's going to be two trauma surgeons um, and also a trauma program nurse, like a nurse manager type thing that will come in with you. So after you do the consultative visit, you got 12 months to really start to get your stuff going. And you basically want to get your stuff all together and make sure you've got corrective actions in place. And that's why doing the gap analysis is really meaningful. So at the consultative visit to confirm these are the things we know that we have to fix. And there's a few other things that we're gonna have to sort out before our verification visit in a year. So it's an online application. You submit it like just over a year in advance. I think they're submitting applications for January to June 2026. So it's all the standards in the grade book. There's nothing hidden. There's this thing called the PRQ, the pre-review questionnaire. So you have to have that submitted, and that's a very big document. It's like hundreds of pages. And that's why you really need a program officer to do this, help you with this stuff. So you need an FTE on this stuff. So you really have to do your homework for this. It's not just something you can do on a weekend. It's quite a bit of work. So your research submission, this is for level 1 centers only. You have to get all your research publications listed so they can review that. And also they're going to grab about 60 charts in about 80 categories, and those are due 30 days before the site visit. And there's different areas, there'll be something like amputation, there'll be something like penetrating torso trauma, blunt traumatic brain injury. There's different categories that you'll have to submit. And at the appendix, all the program documents, like including all your guidelines, all your processes, your terms of reference, all your other things, what meetings you're having, what what is your system of reviewing cases, etc. So it is quite a bit of work. And then a pre-review call 2 weeks prior to the visit, and they'll kind of say, okay, you guys are missing this, you're missing that, like we're going to set up. So now what I believe is happening for our visit is our consultative visit and verification visit were done virtually, including tours using WOW. But what I'm told is going forward for our visits is going to be in-person visits. So that will be good, and because it takes a lot of coordination to have the WOWs touring around the hospital, etc. So it will be, and again, this is not like Accreditation Canada visit. Like they're really serious about this. This is not like everybody's going to get a gold star and pass. This is you don't get a attendance award. It's like they're really serious, and they even fail, of course, American centers on this stuff. It's a 2-day site visit, which for the trauma program manager and the trauma medical director, these are very long, stressful days. I can tell you that much, but well worth it. So the agenda is set by the ACS. They talk to who they want to talk to, and it cannot be modified. You can't say, well, let's put in somebody else. No, they want to talk to the CEO. They're going to talk to the CEO. And that's why it's so important to have your buy-in from your executive. And again, practicing the site visit is the potentially virtual is something that we did, but just with the logistics. And again, and I think you want to have the right people speaking, and how those people identified. Like you just don't want to randomly walk into the blood bank and who's ever there that day to talk to them. You want to have the right people lined up to speak to them that they can answer the questions. There's no trick questions, but you want to have the right people to speak to the specific questions they're going to ask. So this is a pathway. So where we are right now is we're compliant with all our standards. So we had a 3-year verification issued. You can be non-compliant, and you get a 1-year verification and have to go corrective action review, or you're non-compliant and you're not verified. So these are things, and of course in the United States, and Dr. Mulder can speak to it. Some states their funding is tied to passing their verification, so they have a significant amount of pressure to pass this. And here it's Canadian Hospital is tied to this, their funding, but this is the typical pathway, and they will hold it to that, to hold you to that. So the TQIP thing is, and I understand there's some negotiations because I realize the Quebec Trauma Registry is different and there's nuances there. But for the bulk of, trauma programs in North America, if you're going to be an ACS level 1 trauma center, you got to submit your trauma data to TQIP, which in Ontario they've been doing it for years. And also in Alberta they've been doing it for years. So that was easy. That was easy for us. And they'll go through it, and like areas that you're doing well, and areas that you're not doing so well. And I'll just say, time to tracheostomy. It was a part of it's for severe traumatic brain injury. It's just like I'd always tell them about our experience at Montreal General, where trach and peg is just something we're going to do all the time. We're looking for them to do and get them done early to reduce VAP and get ICU movement. But here it was a culture. Well, we want to give them another day, and then sometimes our average time to tracheostomy for severe traumatic brain injury was up to 21 days. It was crazy. So we really had to work on that. And so they really go through this, and with your I can say this is like one of a couple of reports we had after that. We have seen a decrease in our in-house mortality, about a 10% relative decrease in mortality, and that's like 1 percentage point or something actual, but it's we have seen some signals, and I'm reluctant to even say it, but we have seen some trend to decreasing mortality and by some of these things, because you really have to look at the data now and do something with it. And that's what they're really looking for. Are you making up a plan and improving things by looking at your data? Just saying, well, it's okay, we're time to tracheostomy is 21 days. It's like way too long, obviously, but what are you doing about it? We have a slower time to OR here for some various institutional areas, which we've been working on, and we've demonstrated improvement. And that's what they're looking for. They're looking for, do you have to be like a low outlier in all your TQIP adjusted events? No, but you have to show that you're doing something, and you're working on things. So this is ours. What we did on ours, and I'll just be open. It's when we started in 2021, there's like, for the 80% attendance at trauma activations, we started like, everyone's like, oh yeah, I'm there. But when you started recording it, it was more like 60%. And so we started tracking it, and there was a lot of cajoling people and saying why it's important, and like making people show up to the trauma bay for tier 1s. And I'm not going to lie, that is a big culture change. But I can say it makes things better for patients. The decisions are made faster. More aggressive interventions are done, and less people wind up having a bad outcome in the CT scanner, which was when I arrived here. There was, there's always problems, but this gives you the data to do, and you have to do something about it. And so each member of the group of general surgeons that involved in the trauma care must attend 50% of the multidisciplinary peer review committee meetings. So, so this peer review process is probably one of the best things. And people tell me that this is the best thing about the whole ACS thing is the peer review. It means it's only faculty and some senior nursing staff, like our senior OR staff and things like this. There's no trainees, and the cases are presented in detail. So there's no say, well, the resident didn't present it correctly, or well, it wasn't quite like that. It was like this is what the data is showing, and so it's really not focused on individual practice patterns, but it's focusing on like the system. How can we make it better? And a lot of people say that these are the most effective meetings to get stuff done, and people really enjoy it because we deal with hard, there's hard discussions but you bring everybody together that you can actually do things together. And we have that once a month. And it's like an advanced level M&M, but it's really looking at systemic problems. For example, like our tracheostomy issues. So and there's been other issues and like getting patients up to the OR within 15 minutes. That's been challenging at times. And so really working on different policies and protocols and putting it into policy, then it has to happen. And so we worked on something called, for this last one here is the Code Crimson policy. It's basically calling like a code stroke. It means, okay, we're going to the OR right now. And I know Tarek worked on that for a long time. It's like we're just coming up. We're just coming. And so we've done that with buy-in from the OR, from anesthesia, and this is well regarded. And we're all able to collect the data, and we show, if anything, for Code Crimson, we're still under triaging to it. And we're also showing that there's a few unexpected survivors coming out of it, but also a lot of the patients, they don't survive their hospital stay, just showing how sick this cohort is for Code Crimson. So we have this board. When we had after our consultative visit, we had 14 criterion deficiencies and 12 weaknesses, and so we had to start planning. And this is the board we have up when we were doing our first verification, and we started tracking things like this. Things like ASB, things like your alcohol screening and brief intervention. You got to do this. And you have to track all these metrics. This is our tier one metrics. You can see like once people said, oh yeah, I'm there all the time, and then when you actually start tracking it, it was like way less than 80%, and then over time it got better with a lot of, and you give people report cards, how they're doing, etc. So we do this thing called, we do a primary review where our PIPS manager, the Performance Improvement Patient Safety Manager, takes a look at things, and then they get flagged. If there's a concern, they get flagged for secondary review. We have a weekly tactical meeting where we go over all the cases, all the deaths, any problems, all the cases flagged by primary review, and we go over that at our weekly tactical meeting. And then the ones triaged for tertiary review, those are the ones that we go to peer review. And these are usually not provider practice issues. It's usually, which they can be providers can be counseled or educated. It's usually like the systemic issues that we're trying to fix. So this is our results. We did everything we're supposed to do after having 14 critical deficiencies, type 1 deficiencies, and so we were able to do this. I can say that Sunnybrook, they started out with, I think they had like 23, and they were able to do it as well. So it's definitely doable. But some hospitals in New York, they started off with like 50, and they were able to do it. So this is our ACS feedback. So we had quite a few strengths. They did call our QI program state of the arts, and their research was exceptional. So some very nice things there. They liked the Canadian TQIP collaborative, and there was the no CT and ED. They flagged that, and now we're getting one. The FAST exams were not archived. We've had those loaded up to PACS. And the biggest ones, the hardest thing sells for the administration is FTEs, and trauma is a very heavy FTE business, and these trauma programs, and of course the operational budgets. A lot of the executives can struggle with those requirements, but the verification system, here's a list. You're deficient. You need this. So there's at least there's some kind of substance, just other than standing in line with the other programs like transplant or whatever. So these are things we're doing. Um, so our patients really improved the care. I just showed there was, you know, a drop in our mortality on our first couple of TQIP results, and you'll have to see if that's sustained. Lots of guidance, leveraging of resources. I mentioned going to the executive. We got a lot of support from our friends at Stanford University in the US. They gave us tons of support and advice on how to do things because you just don't know. And that's what we want to be for the rest of Canada, giving out advice about how to get your Canadian Center through the verification. Lots of team building and, challenges we had was the cost, and we'll go into that, the buy-in, the workload, the logistics and scheduling. And the virtual hospital tour via Zoom with multiple workstations. But thankfully, that doesn't have to happen anymore. But as you know, the biggest challenge, and I think Kosar and the other leaders, and I'm sure Dr. Mulder has experienced this, is getting the buy-in from people. You have to explain to them why we're doing this, and and you have to expend leadership capital to do this, and not everybody's going to like it. But I think the most gratifying thing when I was able to show the TQIP data that we dropped our mortality, I think that was very gratifying for me to say, okay, look, it's working. So I think it's the end of but it's also keeping the momentum going. Okay, we're not done. We have to do this again. It's not a one and done thing. You have to use your leadership capabilities to keep things moving. So, and we'll go over the cost, which the cost is with the cost of it, the annual cost of this, you can't even buy a good used car for the cost of this. So it's fairly cheap. This is this is the kind of notification you get, and you get your reports and all this stuff, and then you send that to your administrators and say, okay, give us more stuff now, because now we need the CT scanner. There's always a bit of competition, as you know, between Sunnybrook and St. Mike's. And they got their verification before us. And I give a lot of credit to Avery and the guys there, and I train there, so I love those guys. And but they got theirs in December, I think, and so they had this big sign printed up as Canada's only level 1 verified trauma center, and then by February they had to take it down and change it. So it was because it is a big thing. And I think and somebody told me about St. Mike's, and we were doing it for our own local reasons and strategic reasons. But somebody told me from Edmonton, Matt Strickland, he goes, nobody really, Sunnybrook, that's their brand, they're going to do that, and this is what they're going to have to do, and it's not going to be a big deal. But if you guys get it, that means we have to do it too, because if St. Mike's get it, then any trauma hospital level, lead trauma hospital or level 1 trauma hospital can do it. So I like to think us we're the little engine that could, and just showing that this is just not a Sunnybrook thing. It can be a national thing and to improve trauma care across the country. But I give Avery a lot of credit, and he demonstrated a lot of leadership, and they did help us out a lot. And but I guess I feel bad that they only had that poster up for a couple months and they had to replace it. But so this is you put this poster up, this shiny stuff up on your walls. It's all good. This is our current to-do list, and we're apple picking. So we've already collected a lot of our apples, and I've had to do some work. I had to take an online course for disaster management and put my apple in the basket. So you keep there's always something to do and always something to improve. So So the things, as we're kind of near the end here and open up for questions is, so the things with the VRC process to ensure we're getting done a CT in the emerge, which is our CT is on the third floor. I mean, I know you guys at Montreal General is like, oh, there's this long hallway of going to the CT scanner on the first floor, but imagine if you have to get on an elevator with your patient from emerge from the trauma bay, get a CT scan, and then come back down. Like that is just it's crazy. Like it's so painful. So that's something that we're making sure happens now. We're really become the gold standard of QI in the hospital, and it's amazing, like QI and safety reviews. It's amazing, like, anyways, our setting is like the people doing it at the corporate level, they work from home and they have no idea what's going on. And like really they try to lean and steal our resources to do their stuff all the time. We're getting an inpatient physiatry consult set up. We're decreasing the time to tracheostomy. And then one of the main things, we had to increase our OR staffing at night so we could run two A case or 1A cases at night. We're increasing the fracture room time for our orthopedics guys, so they like that. And we're increasing the ASB rates. We're increasing our VT prophylaxis rates. And also we developed our own clinical practice guidelines, and we put it on a trauma app. So for all our residents, and that's another thing they told us that you guys need a trauma app for your trainees, and so we did that. And I'll show you the thing. You can download it for free. But these are all things that are meaningful, and you always have to kind of remind people that people like, oh, that's great, you got us fracture time, thank you. But it's like you have to remind us, like, well, the trade-off is you guys have to keep playing in the with the ACS program to get more stuff. Like this is the delivery is like we are collecting the data, we're doing this stuff, we show you you need more fracture room time, you're getting more fracture room time, but you have to keep participating in this because you guys are going to want more stuff in the future. So anyways, so all this stuff is happening because it's on a list of deficiencies, and this is what you have to do. It's not just Andrew Beckett wandering into the CEO's office and say, "Hey, I want more OR staffing at night because I feel like it." It's like it's this is a deficiency that has to be fixed, and so you do get more attention from the executive on that front. This is you can download this. You can say SMH Trauma on the App Store or Google Play, and these are all our local clinical practice guidelines for download. Just download the app and you can access them all. It's not super slick, but it does work, and it facilitates what we need to do for our residents because we realize all our guidelines and policies and all this stuff. It's like it's either sitting on somewhere on the hospital website that nobody can find, or it's sitting in a binder somewhere that nobody actually knows where it is and if it's updated or not. So this is a way of keeping it updated and keeping it centrally located. So this was and our residents and so onboarding new fellows and residents is like, just like what do I do for, you know, blunt cerebral vascular injury screening? Okay, here you go. Like, here it is. Read about it. Um, most importantly is, you really get the ear of the executive and the organization to buy in because you're a level one trauma center. This is really key. And to show that you're, really like you're really making a difference in the local and national scene because now it looks like, a lot of Ontario is going to be moving towards a verification type program because there is I think some of my colleagues from Trauma Association of Canada, which I'm the past president of, they still want to bring back a Canadian system, but eh, I just it's unfortunately there's just no operational budgets or any kind of organization to do that. So I think the ACS program is going to be the best thing going forward in Canada for a while, anyways. But if there's another Canadian program that's better than the ACS, I'll be the first one to sign up for it. So how much does this all cost? Um, So your consultative visits, they're around, 20K. If you're, uh, these are one-time fees, which are highly worth it. Um, it's again, like I don't think you can buy a used car for 20K anymore. So The TQIP fees, the adult level 1 and 2 quality program. So this includes your TQIP subscription. You're looking at 22K a year. So, and this is to maintain your verification. So, um, it's this 22K fee, like, in terms of overall hospital budgets, this is not insanity. Um, So this, again, these are the standards that we talked about, and it's all in the gray book, all this stuff. So what are the barriers? And I sort of alluded to some of these in the first place. National pride, feel it being looked at by the U.S. and being criticized, fear of not meeting an ACS standard, loss of level 1 standard, because you read like a lot of papers from across Canada from elite trauma centers, and they say we're a level 1 trauma center in upper rubber boot or whatever, and that gets published. And so, and so I can understand some people. It's like, well, if we do this and then they say we're not, we failed it. Like, what does that mean for, you know, in terms of our brand, etc. So I understand that. But it's like, again, the ACS does not um identify level 1 trauma centers. It verifies them. It doesn't designate them. It's just verifying them. And so, it's just, you're just undesignated, unverified. Asking for resources, because you do have to go ask for a lot of resources. The funding, it's a change to the culture and lifestyle, and it's the fear of change and the fear of loss of national cohesion in the trauma community. But ask you is like, which one of these issues that the patients and their families care about? I I think probably, like, people want to know that either they or their families are getting the best possible care in a center that is, met very high standards. And I think that's what people want to know, and that's what I'd want for myself and my family. We can do this. And, if St. Mike's can do it, believe me, you guys can do it too. And I think there's probably even like there's a lot of things that are at Montreal General that I wish we had here. We have lots of Canadian trauma surgeons, ATLS coordinators, trauma program managers, registrars involved with the ACS already. We will have Canadian reviewers. I've applied as a Canadian reviewer, and we have one of the Canadian reviewers at rounds here today. And so the TQEP collaborative is always up and running across the country already, and it's been for years. And at the present time, there's nothing else coming. And I would be the first one to say if there's an amazing Canadian system that was well-funded resources, I would do it too. So, and there's no reason why you couldn't do both. But and I know ENS has a very good system, but to get this international recognition, there's nothing else coming. And once you get your ACS verification, there's other subtle benefits. You start seeing like, oh, like the fellowship applications we get a lot more from the US now. Like it's just a thing. We're starting to see more US applicants coming because oh, I saw you guys are a level 1 center. Like, I'm interested. And I think there's probably other reasons why people are looking at Canadian, but here is like an ACS center. So if I go back to the States, I want to, I want to have that experience as well. So the way forward, Ontario Elite Hospitals, they're booking consultative visits. Sick Kids has an upcoming visit. They had their consultative visit, and they have a number of things to fix, but it looks like they'll get it done. The Ontario Level 3 Trauma Center programs, they may start looking at it. There's interest in British Columbia and Alberta, and of course in Quebec. Kosar is leading that. I think it would be, I think it would be amazing if MGH was the first level 1 trauma center in Quebec, and it definitely get a lot of attention with ENS and everything like that, and it really lead the way, and you would probably improve at ENS as well. I said there's Canadian reviewers coming, so there's going to be some reviewers with some Canadian experience. There's no more TQIP sites coming, and including in BC, and then we had a tax statement about verification, which is this. This is the tax statement that you should be verified by something, whether it's ACS or ENS, or both. And so there's no point in, my perspective is, well, why would we take the gray book and then water things down? Like, we want the best things for our patients, so we should, try and achieve them. And I think, like I saying, many centers say, yes, we're a level one trauma center. Well, you've been designated as a level one trauma center, but I think, as the Russian folk saying says, you want to trust but verify, and you want to go and check that. And that's my talk. So I'll end there.
That's great, Andrew. Thank you so much for that great talk. We have about 5 minutes. There are a couple of comments and questions on the chat, which I think we can probably arrange a second meeting with yourself and Verity to go through those details. But I'm going to open up to the group to see if there's any questions. I see Dan has his hand up.
Hi, Andrew. Great to see you, and thank you so much for this. Hats off, obviously, to you, Avery, and Kosar now for taking this on. I think it's an incredible undertaking, and very worthwhile. My question to you is, a little bit the system in Quebec. A lot of what happens, obviously, in the hospitals is regulated by the province, and so there are risks and it's not that there's risks, but for example, opening second rooms in the middle of the night, that's been a huge challenge for a long time, and maybe this will hopefully be an impetus to be able to do so more efficiently. How much interaction slash support did you get or did you have with the provincial level stakeholders in getting this done?
Not to say, Dan, at least initially, there wasn't a lot of support initially, but there's been leadership changes within the Ministry of Health for the Critical Care Services Ontario and in the trauma lead. And so actually the trauma lead of Ontario now he's pushing it for the standard to be adopted across all centers in Ontario. So still now there's a lot more impetus. And I realize how tightly controlled our facilities are in Quebec by the ministry, and I think sometimes getting the consultative visit and showing them like this is where we're deficient in so many areas, and saying, and again, it's just like having the shiny badge is nice and everything, but it's like it's people may not know how bad it is until an outside organization say like, yeah, you guys need to work on this. This is not like up to standard. And I find, administrators are very sensitive to that. And one of the worst things for them is, talking to them is they told me is like, if we get this, it means we have to commit to this because it's really for an executive to fail a verification. It is not a good look on the executive side. So I think, having outside eyes on the things, because otherwise, people can just ignore the problems.
That's great. I don't know if there are any other questions, but feel free to unmute yourselves. Andrew, this is a great talk. Can you identify some of sort of the secondary benefits for some of the other surgical groups? I mean, a lot of us work with acute care surgery service. What are some of the secondary value added? And you mentioned some of those in your slides with respect to orthopedic fracture care, and so forth.
Yeah.
But
So the areas that I think we realized is like a lot of people who have done, say they're QI experts in the hospital is, well, they don't do anything with it and they don't really know how to do QI in the hospital. And the ACS program is like a cookbook on how to do it. And so in terms of QI programs across the hospital, and particularly in the ICU, like the time to tracheostomy and severe traumatic brain injuries, for example, is they just didn't know how to do it and implement it. But the ACS guide gives you a cookbook about how to do this. And so it raises the standard of all QI programs in the hospital. And so when there's a serious event, it's not like say in other areas of the hospital, like in urology or wherever, it's not uncommon for the hospital risk management people to reach out to our team to take a look at this stuff because we're realized we're sort of raising the boat of all QI in the hospital. And I think and I think getting the CT scanner and emerge, and we'd looked at the data, like for trauma scans, it's only about like 17% of all scans, that, from emerge that, are trauma. So that's going to be a big benefit for emerge having their own CT scanner and avoiding that elevator trip for every patient with, belly pain. Like it's going to be a huge, cost saver in terms of labor and resources and time, and emergency room wait times. And I think the other things that, is increasing the OR time, and who benefits from that? Well, it's many services in the OR benefit, including transplant. If there's a renal transplant program here, things like spine and things like this. So there's many areas that have benefits, and um, so it, raises, like, it's really a program that raises the level of care across many disciplines, and and including like even the VTEs, the deep VTE folks, the anticoagulation folks, is like we really need to start improving VTE prophylaxis in the hospital. Like, yeah, we just don't really know how to do it. Well, like here's the data. Like we're having P's all the time. And it's like, well, yeah, we wanted to put a guideline together for next year, but we didn't, it's like, well, this is how we're going to do it. And this is the QI process, how you're going to do it. And then you see the VTE prophylaxis rates going up, and and so it's kind of, validating in that it's, you start seeing the results of these efforts, because it's just there's so many things going in the hospital, and everybody's focused on what is the catastrophe for today, instead of really planning what are the underlying issues and fixing things. So it is really in a cookbook how to do it. Like, it's not, for sure, if I can figure this out and implement it without a QI training background, like I mean, anybody can. So
That's great. Andrew, there's a lot of people signing off because they're going to the OR, but I don't know if there's any other questions. Please feel free to ask. Otherwise, for those leaving to the OR, thanks for joining this morning. So if there's no other questions, thank you, everyone. Andrew, thank you for giving this lecture this morning, and accepting the Boyd lectureship, and hope to keep in touch with you, and have a follow-up meeting. Thanks.
sounds good. Thanks, everyone. Good to see everyone. Take care. Bye-bye.
Bye.